the sessions by opening the Urology Symposium, Pearls in Urology. And we have got a number of eminent speakers who will be sharing their knowledge with us this morning. And to start with, may I introduce Professor Abhay Rane, who is no stranger to this audience. And he's a consultant urological surgeon, and he is the Vice President of Royal College of Physicians and Surgeons, Glasgow. He was appointed by Her Majesty Queen Elizabeth II as Officer of the Most Excellent Order of the British Empire in 2014. Honours list for services to his pioneering laparoscopic surgery in United Kingdom. He has keen interest in surgical education and training and mentoring, and he is a frequent and regular visitor and an examiner, external examiner in most of our exams, especially the exit exam in urology. So without further ado, I will invite Professor Abhay Rane to deliver his lecture.
Good morning. Thank you, Neville, for that kind introduction. It's always a pleasure to be in Sri Lanka, and even greater pleasure to be amongst urologists. Now, we'll have to say that quietly, because this is a college of surgeons, and they outnumber us many hundreds to one. Anyway, thank you for coming. It's early, and I think the coffee hasn't quite kicked in, so we're in single digits, but it's quality, not quantity. We have two presidents of very big associations here. It's Sanjay and Mike, and so, as I said, we're beating everybody on quality at the moment. Let's talk a little bit about artificial intelligence, and we'll talk about what it has to do with our specialty in urology. So this is Google. Google, as you know, has invested heavily in AI, and you wonder why. Sometimes, because Google has its fingers in so many pies. And I've just put up a statement that Google made, that it believes that AI is a foundational and transformational technology. So it's going to affect all of us, whether we are prepared for it or not. It already is, and we are being assessed, manipulated via AI without being aware of it. But if we harness that power properly, it can do a lot to help us in treating patients, which is what we do. And we'll talk a little bit about how we can do that. So, who will it affect? And I think it's going to affect everybody. And we, as urologists, have a somewhat lucky, somewhat, history of being at the cutting edge of technology. So even, when lap came on, we were there right at the beginning. When robotics came on, we were there. And so we led and others followed. And so I think it may be that some of the applications of AI will be urology-centric. Let's talk a little bit about what AI implies, and I'm not going to sort of give a didactic talk on, the semantics, but there's four ways in which AI affects us and how it goes about it. Machine learning, and basically it's technique-based programming. The computer picks up data, analyzes it, and then it just sort of goes through the data and becomes very good at identifying algorithms which pick out abnormalities. There's natural language processing. So it extracts the information, the bit that it thinks is important, It's like your medical records, and it can scan your medical records in a fraction of a second and throw out what we think would be important for that patient. Artificial neural networks aren't new, but now they're coming into their own because they can form part of deep learning. So this is, trillions of neurons or the equivalent coming together and recognize complex patterns. And then they look at those patterns and they pick out bits that don't fit and then give it to us to analyze. So these artificial neural networks are actually getting much better. And these, I think, are going to influence what we are going to do in urology a lot. And finally, this computer vision. This is where we already are in the process of utilizing AI to a certain degree of confidence. And this is where we get images and we can analyze them and we can use that image to determine how best to operate or approach a tumor, to do, say, a prostatectomy or a partial nephrectomy. Computer models, all of these are being used at the moment, and they're just getting better as time goes on. It's because I think urologists have already invested in the AI kind of way of thinking, because it helps diagnose and treat. Anyway, let's look at AI slightly differently. I mean, AI is a generic term, and the question I would ask is, if we ask a generic question to a different AI module, would you get the same answer? Because that's what it should be about, isn't it? If you ask a machine an answer, it should give you the same answer if that is what the answer is. Now, Manjula is not here, and this is kind of thrown my talk a little bit, because on the original program, Manjula was going to be sitting with Neville. So if you put into ChatGPT, Manjula Vijayvarna, urologist, interests. And this is what GPT comes up with. Oh, I can't tell you about him, can't access personal information. So his interests vary widely, so you should contact him directly. And okay, that's fine. So then you ask the same question to Bing AI, and then you get a bit more information. And you get that he's a consultant at the National Hospital of Sri Lanka, and his interests are bladder health, prostate health, education and training, and some messages from him. So you get a bit more information. So you're putting structure onto a name. This is just from your computer. And then you go to Bard Google AI, and you get even more information. And I won't read out everything, but what's interesting, if you see the box that highlighted, he's also interested in artificial intelligence. Now that I wouldn't have known unless AI had told me, but I had to dig deep to find that out. I was going to ask him which bits that he, was he really interested in, but maybe that's a question I'll have to save to ask him when I see him next. However, you see where I'm coming from. You ask the question, but you have to ask it to the right search engine, and you have to couch the question in the best possible framework that the AI engine will understand. Now, let's move on. Artificial intelligence applications in urology. Again, I put this to Microsoft Bing, and this time it was a bit more generous, and it gave us some ideas, or its ideas, of what it thought AI could do in urology. And you can see they're talking about, kind of very generic, very vague terms, but some kind of specifics about diagnosing urological cancers and, semen parameters and stuff like that. But again, very woolly. Same question asked to Bard AI, and you've got, you get data sets, you get trial names, you get studies. So what I'm trying to get at is, I'm not saying that Google AI is better than Bing, although it appears that way. It may be for this particular exercise, it did give us more. But I think we need to have some way in which this could all be brought together. Because, you know, AI should be able to give us what we want without us having to keep looking for it. And I think that's where I think we'll need to work towards some sort of solution, working with the industry to make that happen. And that's a very generic statement, but I'll quantify that. So if you look at this was from the BJI. I think it's 2 or 3 years old, but you know, actually it's 2019, so it is about 4 years old. But even in 2019, we were looking at this, and Prokar Dasgupta is a very good friend of mine. He's a chair at KCL in London, and he's done a lot of work on AI, and they have an AI program that is ongoing at KCL. So the interesting thing is that we saw the application, you know, about 5, 6 years ago, and have been working and running with it. So this is just some data about that paper. You had 111 articles, and that was a breakdown of what they did. And basically, we had a very generic outcome from that paper, that even in 2019, it was widely adopted, and it's more accurate, and gives you better options in larger data cohorts. And it, you know, the evidence base will help us provide better health care and individualized patient care. And that we can see that happening. Now, this is a paper from, I think, last year. And this is an interesting paper, because what it does, it pits AI against human intelligence. And if you look at what they did was they took about 10,000 biopsies, out of which they took a sample for validation, and then they, you know, it was split across a number of sites, so there was enough confounding factors there to make this validatable. And then the aim was to automatically grade biopsies and assign a Gleason score. Straightforward. Pathologists do it all the time. And so the deep learning system used data from this cohort of about 1,200 patients, and the system outperformed 10 out of 15 pathologists in a fraction of the time. So this wasn't to show that histopathologists are slow. It actually shows that the AI can help, because it makes, you know, data churning and data processing much more of an easy task, and it's you know, it's data that is validatable. And so this is just a glimpse of what AI can do for us if we apply it where we think it will do the most to help us, just speed up data processing and give us the histology we need. And I can see this happening for a number of cancers. Let's look at prostate MRIs. It's a slightly different subject, but again, what does a radiologist do with MRs? He takes a squiggle of gray and black and comes up with what that should mean in a prostate, and gives the appearance a score, a Likert score or a Pyrad score, and we base what we want to treat patients on that score. And Autoprostate just did that. And what they did was they got AI to analyze all the prostates. And we'll cut to the chase. There was no difference between the AI machine analyzing those MRs to assign a Likert score and a senior uroradiologist. Okay, you know, more work's going to be needed. But again, I bring you back to what I said. The radiologist would take, whatever, 10, 15 minutes, maybe more, to analyze one set of MRI scans. Autoprostate did it in seconds. So I rest my case there, because it is something that will help us move on much more quickly in getting our diagnosis to the patient and then, offering them treatment. One of the delays we have in England is this distinct lack of uropathologists. There's a shortage. So something like this would help us. This is Harsh Chandak. I was his PhD. He was my PhD student. He did these models at King's, and he took a long time getting his PhD, but we gave it to him this year. Basically, he had these models where these were cognitive, and then he created these models based on his cognitive parameters, and then put them into an algorithm that kind of correlated what the cognitive appearances were with the model and with the actual histopathological specimen. So if you 3D print them, you can reduce the surgical margins because you know where the tumor is likely to be present. And so these were all cancers of the cervix. He's a gynecologist. But you can see where I'm coming from. It's the same principle. This is the Urology Foundation trial, and bear with me, it's a busy slide, but basically the Urology Foundation is putting this into play shortly because it's been approved, and I think they're just getting the centers together. But all of the patients will be, you can see in the top line, they'll have all MRIs, and they'll either be divided into a group that gets automated septation or gets surface model generation, like I showed you earlier. Then below that, they'll either go into standard practice, intervention group 1 with 3D printed models based on the MRI, and the intervention group 2, which will have virtual models, and then we'll look at what that shows. NHS AI Lab is up and running, and you can see that even the NHS has invested hugely in AI. The accuracy, it's good, but it could be better. We can use AI at the moment to assist urologists rather than replace them. I think that's the important thing. This is the most important slide. It is whether use of AI is going to be ethical, and it's certainly not something that is easy to put into focus, because ethics are still, we're not sure what sort of ethics we need to apply here. But certainly a lot of them are important because we have to be transparent about where we got the data from and how we use it. And it's ultimately the public has to trust the data that we generate from AI. So I'll leave it at that. I'd like to thank the College of Surgeons of Sri Lanka. I'll thank Neville, and hopefully Manjula can have a look at these slides later. And of course, Ajit, well done yesterday. And I have to acknowledge Prokar for all the work that he's done. So thank you all for your attention.
I think because we have little time, what we thought was that allow questions for 5 minutes, if it's okay. I think that is for the lecture, and then we'll give 5 minutes because the topics are going to be a bit of diversity in the topics, so that rather than, so if it's open to the audience to ask questions from Professor Rane.
Srinath.
Any bit of AI that is there any AI being used for clinical work actively in the moment at the NHS?
Only in the context of trials.
Only in trials.
Yeah. I think the difficulty is having the confidence that you are not going to be worse off than a human. And I don't think we yet have that data to give the confidence to the public. Now, I suppose it's what you disclose is the issue. Once NICE looks at it, goes through the data and is confident, then we will move towards a kind of hybrid approach where a certain percentage will be given to an AI module and a certain percentage will be given to conventional histopathology setup, for example. And then they'll look at, over a period of time as to whether there is any big difference. And that's the time that we'll be able to pull the trigger on that. But nothing yet. It's just still very much in the context of trials.
Neville. Abhay, good morning. So it seems every time we invent a new machine as human beings, we think it's going to give us more time. Whether that's a car for travel, an aeroplane for travel, we're going to get something back which will allow us to do more. And what you seem to be outlining there with AI was that the different levels you gave still need human interpretation, so that no matter how clever the AI is, it still needs somebody to look at it. And I think we've been getting a little frightened, and certainly in the UK, that AI is going to take over the world. But I think what you outlined is still human interpretation. On the business of images, on the histopathology, I think we now have reasonable evidence in the UK that for pigmented skin lesions, the AI is just as good as the pathologist, and we can begin to take a pathologist out. On mammograms, mammogram reading, the AI is as good as the radiologist. But what we don't seem to be designing yet is algorithms which acknowledge that expertise and have the AI reporting 24/7, 160 hours, and then putting the human check-in on top of that. Is that the likely model for this, that we'll get the AI to review the images 168 hours a week and give a human being a smaller quantum of work for checking?
I can see that happening as a sort of check and balance. I think when I had these discussions earlier, I think one of the lay person in the group that we were having discussion with said, actually, if humans make errors, it's put down as human error, and we would accept that. If this was a computer error, that would not be acceptable to the public, because a computer isn't supposed to make errors. So I think that's where we still have the gray area. But as you say, if there is a certain top slice of, say, the AI infrastructure went through 1,000 images and randomly selected 6 or 8, or we selected 6 or 8 of them for validation, I think once you have a critical mass, you'd be able to do that. And I can see that coming, because as you say, they are as good. And at the end of the day, they look at what the human eye is looking at, but they look at it much more quickly. So yes, absolutely. It's a confidence thing. I think it will happen. It'll have to happen. As, the way we started was, PSA-based prostate cancer screening has come in by stealth. There's no evidence for it. PSA is not a tumor marker, but we are using it, and everybody who has an elevated PSA gets an MR. And if you think at the number of MRs that are being done now, if we had something like an AI tool to help analyze them, they could all even be done in the community. So you'd go from the community, have your MR, have it interpreted by AI, and then depending on what that showed, you could then come and see the urologist. So that may be something that might come in. Sanjay?
Yeah.
Thank you, Mike.
Abhay, it was a very nice presentation. And basically what I want to ask, that the current system where all the research and everything, when it is going, means what I feel that the system is enriching the richer. Do we expect this to percolate to the masses? When what I want to say, for the common surgeon, those who often find difficulty in decision making, handle the situation. So will it be something which we see in near future?
Well, it's a very good question. We're seeing it already. So when I sit in my clinic, there are generally 2 or 3 types of patients, but the one that I get really worried about is somebody who comes in with his cell phone open. And if he has got, say, aggressive prostate cancer, and I tell him, what I think would be the best option for him, and then he's got all his, the questions that have been generated from AI and the answers with the data sets, with the statistics, and that's what you have to contend with. Now, the one good thing that we have is that AI can only go back to 2021. It hasn't caught up to the current papers. So one of the things you can say, well, actually, the current data suggests X, Y, and Z, and you've got to have the current data to hand. But that's a fudge, because the patients come armed with sometimes more knowledge that you can carry in your head. So I think what it has done is shown us that we can't be complacent and dictatorial and say, this is what you should have. You need to have a way in which you can explain to your patient, this is what I think. That you may be better off having a radical prostatectomy. And then if you want to have radiotherapy, well, that's also fine. If you want to have brachytherapy, well, perhaps that's not so fine, but yes, it is an option. And then I generally offer them a second opinion. So it does influence how you work. And I think it's made me a better surgeon because I think I've managed to accept the fact that what I say is not necessarily what everybody wants to hear. So yeah, if they want to have somebody else give another opinion or they have better evidence and they're convinced by it, yeah, that's fine. We can make them happy, and everybody walks away from the table having done the right thing. So it's interesting.
Thank you very much, Professor Rane, for stimulating such an active discussion. If you would like to join us up on the podium. Yes. Our next speaker is looking at the future of stone management. He is Dr. K Vickneshwaran, consultant urological surgeon from the District General Hospital of Vaunia. Over to you, Dr. Vicky.
Thank you, Chairpersons. Good morning, everybody, again. So I would like to talk how to manage renal stones. So how small is small? So this topic is a little bit like where are we going to start, which is the smallest one, whether we think the big stone is going to be a small, so how the urologists are handling those. So we know, we can start with how we manage the stones, and in time to time we'll talk about the small stone and how we think it's a small. So why the introduction, the increasing prevalence of stone disease and risk more, especially men about 10 and the women about 7%, and there is a recurrence. That's why the stone disease is more common, more important in the life. And there are a few stimulating scenarios. You say a 50-year-old man with 4 centimeter lower polar stone, no symptoms. Do we need to handle or do we need to do any surgical procedure? There's a second one, 25-year-old boy with bilateral small few millimeter stones. Do we need to do incidentally finding? So they went for some other investigation and they got these small stones. Do we need to handle this? And another common, the lady, 60-year-old lady, 3 millimeter lower polar stones, complaining of back pain and hematuria. So how we are going to manage these small stones? Right. So anybody, patient coming with stone disease, we have to go for the basic investigations, a blood urine workup, and imaging the basic with the ultrasound scan. And if required, we have to go for a septic screening in patient with sepsis. Right. The definitive evaluations, which include mainly we have to go for a history, and proper examination. That is very important to manage stone disease. Not like other stone disease also now changing, it's a metabolic syndrome. So it's having so many other diseases are connected with the stone disease. So history is very, very important. And also the imagings, we have to go the imagings, and then we have to go metabolic screening part. So the screening, the main one, the CT scan, the non-contrast CT is the gold standard. But this is the first line. When you see a patient of a stone disease, that is, you have to do a non-contrast CT, 99 sensitive, you can find the stones, and from that you can start the treatment plan. And DECTs, so the dual energy CT scan is important, especially only for the uric acid stone, where you can nicely see the uric acid stone. And the cultural practice, we go for a non-contrast that's called extra KUBs. Is it important to do extra KUB? So extra KUB is not really important, and if you do a CT scan, the first field is going to be extra KUB. But so in the practical point, if you are working in a peripheral settings, the extra KUB is most important, where you can see whether the radiolucent stones or the radio-opaque stone. And also, now if you want to follow up the patients, easy, if you have extra KUB, if you see a stone on the extra KUB, then you can follow easily than doing a scan on the next follow-up. So, and there is a small things now we have to change. No need of bowel preparation. Still the people are practicing bowel preparations of normal patients. If you have a normal bowel habits, you don't need to go for the bowel preparations. Generally, you can take extra KUB then and there, and you can see the patients. And so metabolic screening again, so you have the low-risk metabolic workup and you have the high-risk patients. We'll see later what are the high-risk patients. So the low-risk, generally, normally blood ureas and electrolytes, uric acids, calcium, phosphates, and pH cultures and crystals. These we have to do all the stone patients, and if possible, do a stone analysis as well. So this is for generally for all the stone disease. Will give a fairly a good idea of what type of stone and all. And high-risk people, we have to think about 24 hours urine collections where calcium, oxalate, urate, phosphates, and citrate, that to go for the further special investigations. Right. And then how we manage the initial part is a pain. So pain, they give a different painkillers, pain setups, different people have different policies. Basically, the first line, you start with non-steroidal anti-inflammatory drugs, and also the paracetamol you can give. And then second, you can go for opioids. Yeah, so here, if you can't control the pain by giving these all painkillers what we have, and then the procedures or a stenting is also indicated. You can do interventions to, especially only for the pain. Right. Then we have to handle obstructed infected system separately. So these are urological emergencies. Always go and do an investigation, special imagings before the intervention. This medico-legally it's covered. And then second things, if you do a stent, you won't be able to see the stone clearly. Better you go for imaging studies and then you go for a intervention. And there is a discussion on whether you have to go for a stenting or nephrostomy. There are advantages and disadvantages, you all know. Nephrostomy is very easy, local procedure, a large tube, quickly drain, short pathway, so patient clinically is improved very well. There's a problem, patient has to carry a bag. But as a stenting, no need to carry a bag, but you need to do some sort of anesthesia, and it's a smaller tube, but this patient is more easy, you don't need to carry any bags or something. Right, and depending on the facilities available, whether you have a good radiologist to put it then and there, put the nephrostomies. Right, so this is any obstructed systems, so patient need any form of drainage, whether nephrostomy or PCN. And then the definitive treatment should be differ. So you have to delay the definitive treatment. Always get the culture from the urine that you are draining from, and then send for culture, but you don't need to wait. You start the empirical antibiotics, and when you get a culture, you have to revise and you have to go for the change the antibiotics. And then now we come to this normal pain. What we're going to see, we can observe the patients, and then you have to go for the treatment. Very small stone, less than 4 millimeter, 2-3 millimeter, no other complication, no infection, no hematuria, no other problem, then you can keep under observation. And anything more than 4 millimeter have to be in the active management. We'll see. Right. What are the armamentarium the urologists have? We have ESWL. Now it's developing very, very fine methods. And then we have minimally invasive interventions like a flexible ureteroscopy, rigid ureteroscopes, and there's laser and the stone breaking instruments. Right. For these undergraduates, they know what are the indications, what are the contraindications of ESWL. When you are referring pregnancy patients, you try to avoid or is contraindicated, coagulopathies. So infected system, obstructed system, and patient with aneurysm, we contraindicated. And cautions are severely obese patient, you won't be able to locate the stone, and and the large stone and small stones, soft stone, very hard stone, and lower calyceal stone, mainly in the very lower down, ESWL is a little bit cautious. And minimally invasive procedure, I have told you earlier. So these instruments are now getting more and more very fine instruments, the high technology. So the most of now they have moving towards endoscopic management. Now we come to these ureteric stones. We know general arbitrary numbers. We say as 95% of the ureteric stone less than 4 millimeter is passed spontaneously at a period of time, say about 40 days, 95%. But say what's happening to the 5%? So still there are 5% area where the stones can stuck in the ureter. So we can't just say numbers say that every stone can pass. Even those 1 millimeter, we have seen 1 millimeter, 2 millimeter stones blocked and patients got sepsis and managed in ICU. So it's very careful, even managing any ureteric stone, even any size of the stone, we have to follow up properly. And so generally say the stone average, when you give a medical expulsive therapy or treating the ureteric stone, we have to see at least 30 days. And if the stone is not moving for 2 months, it's very rarely the stone is going to pass. And the medical expulsive therapy will give alpha blockers. There are different types, different names, so many. So we just start whatever which is available on your place. So this is another important. There's never assumes this stone is going to pass, right? Sometimes they have a big stone, patient can pass simply, the small stone can block. So no assumes, don't say give a false assurance to the patient. So that's the commonly happening. We see patients in the periphery, especially patients coming with ureteric stones, they give the medical expulsive therapy and then say, no, you don't need to worry, the stone will go. They will come back in 6 months with completely obstructed, non-functioning kidneys. Even very 3 millimeters, 2 millimeter stones also can cause. So always obstructed system, any stones in the ureter, you have to give a proper plan, how are you going to manage those stones. So you have to make sure, the patient, you have to make sure by investigation and scan to make sure there's no obstructions before you discharge the patient or keeping on a follow-up plan. So if the stone is more than 5 millimeters, should closely monitor by a specialized center like urological clinic, and then this patient has to come regular clinic follow-up. And when are we going to intervene the ureteric stones? So we have given the treatment, it's not really working, so the stone is not progressing, and patient, despite giving a good painkiller, still patient is having a pain, and obstructed patients, and patient is, the renal function is like renal insufficiency is there, so is a rising creatinine, we have to consider the treatment. So always we say a ureteric stone, you can try ureteroscopy, that is well-developed system now, or the ESWL. So usually there is a discussion on URS, ureteroscopy, and the ESWL. So what is the advantage? Your ESWL, so you don't need anesthesia and all, it's a simple procedure, but you have to go for multiple sessions. But ureteroscopy, single procedure, but you need anesthesia. And ESWL better with a smaller stone less than 1 centimeter, and you have to give a shock waves about 60 to 90, and that improve the stone free rates. And lower polar stone, hard stone, oxalate monohydride stone, and obesity, where the ESWL is not really very good. Right, and then we see the renal stones. So there is an argument. So earlier we managed conventionally the open surgical procedures. That is the most common for the large renal stones. Nowadays there's no word called large renal stones. Most of the stones we manage with endoscopic procedures like PCN and a lot. And the lower polar stones, still there is a specific consideration of a lower polar stones. And what is the intervention is advised, any stones more than 4 centimeter in the stone growth. Right. And this patient need a proper follow-up, and we have to plan for a proper intervention. Stack cones, if you see a stack cone, you can't advise the patient, you can leave it. These scans, there are evidence that can cause a renal loss. So we have to follow, you have to do a proper assessment and go for the surgical procedure. The renal stones, so what are the indications of recommended indications? So say the stones more than 5 millimeter, symptomatic stones of pain, infection, hematuria, stone causing obstruction, and then the patient preference, especially surgeons, pilots, long vehicle drivers, those people can't have even a smaller stones. You have to consider their occupations, and large stone like stack cone calculus, you have to plan for interventions. So we have dissolution therapy and ESWL, endoscopic intervention, and PCNL and open surgeries. Right. The dissolution therapy, we all know, it's only for uric acid stones we can consider. So we have to maintain the pH. Prevention, we have to be 6.2 to 6.8, but dissolution is like, say, we have to keep 6 or more and 7.2. So we have to advise the patient to maintain the urine by urine dipsticks, and according to, you have to increase the doses. Right, and then the stones in the mid calyces and the upper calyces or the renal pelvis, we manage almost all three in the same way. Where what are the options which are available? We can go for flexible ureteroscopy or ESWL or PCNL, where the mostly the more than 1 centimeter ESWL is not the first line options because the bigger stone. So the option we have upper ureteric stones, the renal pelvic stones and the upper ureter and the mid calyces and the upper polar stones. You can consider right. The ureteroscopy now is it's more developed compared to the previous stage. They have a very fine and chip on tips, and it has a very fine lumen. So most of the ureteric stones and the renal stones managed with flexible ureteroscopy and the fluoroscopy. And small and other important things we have to know the PCNL. PCNL, now we have the simple PCNL, there's so supine change to supine, and additionally they have a single dilator systems, and they have a tubeless system and is well developed now. They is very good for managing upper ureteric renal stones. So these are the position, earlier we used prone position, now we use supine positions. The high-risk patients are, I told you, the patients are getting stones in the young age, family stone disease, and the high temperature zones and some metabolic syndromes, hyperparathyroidism, where a neurological patient, they will get stones again and again. Patient need a proper follow-up, so there's a high chance of recurrence. And there are three important things we have to do. How are we going to prevent the stone disease? So intake, urine intake, so the water intake, you have to be 2.5 liters minimum and produce at least 2 liters of urine per day. And nutrition, you have to give a balanced diet, vegetable-rich, fruits-rich diet, and avoid salt, and the lifestyle modification, active lifestyle. We have to maintain the reduce of the BMI, balanced diet, fluid intake, avoid alcohol. Those all very important to avoid stone disease. So the decision of managing stones is multifactorial. We have to have a rational approach. Very small stones also need, in some situation where the patient going a recurrent infection, hematuria or bleeding, or patient having a back pain, consider that stone is the cause for the pain. Otherwise, we can follow up. All the stones should be managed in specialized, especially urological specialized stone management centers. Thank you very much.
Thank you, Dr. Vickneshwaran. In the interest of time, I think we should call upon the next speaker. We are moving from the upper tract to the lower tract. Dr. S Sasikumar will be presenting the final presentation, and he is consultant urological surgeon at the District General Hospital at Hambantota, currently working as at the same place. Yes. Dr. Sasikumar, over to you.
Good morning, everybody. And the topic here is update in management of prostate obstruction. And here we mainly consider about the benign prostatic obstruction, which give rise to lower urinary tract symptoms. The presentation includes the evaluation and management of benign prostatic obstruction, medically, surgically, which includes minimally invasive procedures. So we all know the benign prostatic obstruction. It's an enlargement of prostate due to androgenic stimulus by dihydrotestosterone, which is a metabolite of testosterone by the action of enzyme 5-alpha reductase. Considering the risk factors, it includes age and presence of functioning testicles due to their hormonal influence. And in addition to that, there are associations between the metabolic syndrome, diabetes, obesity, race, and cardiovascular disease. So, when we consider the benign prostatic obstruction, it's prevalent in aging male. With increasing age, the LUTS symptoms, the prevalence of LUTS is between 10% to 30% in men in their 60s and 70s, and 70% in their 80s. So there is and in addition to that, there is a strong age-related increased risk of any treatment in those patients with LUTS. So the benign prostatic obstruction contribute to male LUTS complex via considered with at least two routes. One is through the direct outflow obstruction from the enlarged tissue, that is the static component, and while increasing the smooth muscle tone and resistance within the enlarged gland, which contribute to the dynamic component of the obstruction. So, when we consider the microscopic benign prostatic hyperplasia is nearly present in 50% in 60-year-old man, and it increased to 90% when it comes to 85-year-old men. So, in those 50%, only 50% have the benign prostatic enlargement, that means microscopic enlargement. Among those, only 50% have the LUTS associated with benign prostatic obstruction. So, although LUTS and LUTS associated with benign prostatic obstruction is not often life-threatening, it has great impact in quality of life. So finding an enlarged prostate in an ultrasound scan is not an indication to manage or treat the patient. So we are not going to manage benign prostatic hyperplasia or macroscopic enlargement. We are going to manage the patient with LUTS to improve the quality of life. So there are a number of community-based studies which shows the important motivation for patients seeking for medication is the severity and of the symptoms and degree of bother. So we are going to manage those aspects while considering the treatment rather than managing the enlarged prostate or benign prostatic hyperplasia. So when the patient presentation, when you consider the patient presentation, they may present with lower urinary tract symptoms or even with a complication, something like acute urinary retention or acute kidney injuries. And most of the time, the patients present to the general practitioners and other medical specialties, including the general surgeon, before coming to a urologist. So therefore, it is essential to identify the LUTS-related blood outflow obstruction from the other causes and by all the other medical specialties. And here I am outlining the evaluation and management here. So above the age of 40 and 50 years, one of the common cause of LUTS is benign prostatic obstruction among the lot of other causes. So as from the medical school teaching, we have to evaluate these patients with a medical history to rule out any potential causes of LUTS and to find out the relevant comorbidities and medications that may relevant to the management of these patients. And benign prostatic obstruction, most of the time, is a disease of elderly population, and already the significant number of patients have the sexual dysfunction. So the treatment-related, in addition to that, the treatment-related blood obstruction affect the sexual function. Therefore, it is important to know the baseline sexual dysfunction, preferably by a validated questionnaire such as International Index of Erectile Function. So to assess the symptom severity and the quality of life, the IPSS score, the International Prostate Symptom Score, is very important here, and it's a validated questionnaire. And an IPSS score, it's considered to be filled by the patient, so it's time consuming, and patient literacy requires the patient literacy and the good cognitive function and good translation in our country. So frequency volume chart give an insight about the patient LUT symptoms, and considering the physical examination, the digital rectal examination, which allows us assess the approximate size of the prostate, and it may reveal the malignant prostate as well. In addition to that, physical examination focus on the suprapubic areas, external genitalia, and perineum and the lower limbs to look for the other causes of LUTS. So continue with the evaluation, the basic urine analysis that give a good idea about the overall picture of LUTS symptoms, and postvoidal residual volume and uroflowmetry is helpful assessing the patient regarding the symptom severity and risk of progression. And when we consider the PSA measurement, it should be considered after discussing with the patient about the pros and cons, and it may reveal the underlying malignant prostate. And it has, in addition to have a good predictive value for assessment of prostate volume, and it's a strong predictor of prostate growth. So primary goal of treatment is to alleviate bothersome LUTS. And in addition to that, treatment also focused on disease progression and complication of acute complications such as acute urinary retention. So depending on the severity and symptoms, the quality of and life, treatment modalities need to be tailored. So natural history of benign prostatic obstruction is very slow. And serious complications are infrequent, so therefore it's rational to consider watchful waiting with lifestyle modification and behavioral modification in those patients with mild symptoms without much impact on quality of life. So there are a number of pharmaceutical agents with different mode of action and different side effect profile, and they can be used as single agent or as combination treatment depending on the patient symptomatology. So we know the alpha blockers, those are the first line treatment here, and it reduces the patient symptom by 30 to 40%, and while improving the urinary flow by 20 to 25%. And adverse effect profile include deafness, ejaculatory dysfunctions, and floppy iris syndrome in patient going for cataract surgery. So the 5-alpha reductase is indicated in patients with demonstrable prostatic enlargement. So 5-alpha reductase inhibitors, it provides moderate reduction in symptoms and reduction in prostate size and reducing the risk of acute urinary retention and need for surgery in the future. But the thing is, it has a latency period for this improvement for about 3 to 6 months. And considering the combination treatment, the alpha blockers and 5-alpha reductase inhibitors, there are a number of studies, including initial studies of MTOP study and the COMBAT trial. Those considered the combination therapy reduce the relative risk of acute urinary retention and BPH-related surgery, and it has improved the symptoms to a greater extent. And there are other combination therapies depend on the patient's symptoms, particularly in patients with secondary overactive bladder symptoms associated with benign prostatic obstruction. We can use anticholinergics such as solifenacin tolterodine, or we can consider beta-3 agonists such as mirabegron to reduce the overactive bladder symptoms. We all know that phosphate diestrase inhibitor, type 5 inhibitors used for erectile dysfunction. Here, particularly the drug called tadalafil that improve the IPSS score, particularly the related to blood symptoms. In addition, it improves the erectile dysfunction. Those patients with blood symptoms associated with erectile dysfunction, we can consider tadalafil. In number of studies, it has been proved. So, in patient with patient can present with complications associated with lower urinary tract symptoms, such as acute urinary retention. So, in patients, we can consider the alpha blocker prior to trial without catheter, and at the same time consider avoid trial without catheter during the active urinary tract infection. And consider the surgical treatment. Since the advent of medical therapy for benign prostatic hypertrophy, there is a steady reduction in surgical treatment. Since between 1999 and 2005, there was 5% per year reduction in TURP, particularly in US, and there was another significant reduction from 2005 to 2008. It may be contributed by the other minimally invasive surgeries as well. So the main indication for surgical treatment is a failure of medical therapy. In 1988, at the time of before the introduction of medical therapy, the indication was 0%. That means all the patients undergo surgery. It gradually increased, and by 2008, it's nearly 87% of the patients go for surgery because of previous failed medical treatment. So other indications include refractory urinary infection, retention and recurrent UTI, bladder stones, refractory gross hematuria, and intolerable to the side effects of the drugs, and patient not willing to take the daily medications. The surgical treatment include transurethral surgery and minimally invasive surgery and the simple prostatectomy. When we consider the transurethral resection of prostate, that is considered to be gold standard even at this point. And considering the morbidity associated with the TURP, we know it has the intraoperative complications such as TURP syndrome, and it has early postoperative complications such as hematuria infection and late complications such as strictures, bladder neck fibrosis, and urinary incontinence and retrograde ejaculation. So, somewhat the bipolar TURP compared to the monopolar TURP alleviate the complications such as bleeding and the TURP syndrome. So, the TURP surgery has been declining since 1987, and this graph shows the trend of TURP, particularly in the USA, but the pattern is different in Sri Lanka. Because of the other minimally invasive surgeries, the TURP numbers are reducing at the same time. The minimally invasive surgery increase gradually. Considering the minimally invasive surgery, there are a number of modalities available, but when we choose, we have to assess the patient factor and we have to discuss with the patient before, and considering the side effect profile, we have to select. The prostate urethral lift, it can be used as an office-based procedure and used for prostate volume of 30 to 80 cc in the absence of obstructive median lobe. And here the urethral lift procedure alters the prostatic anatomy without ablating the tissue via a placement of a transprostatic suture material. The implants that will pull the lumen from the prostatic urethra towards the capsule and thereby widen the prostatic lumen. The advantage here is it preserves the erectile and ejaculatory function. So there are other devices, the temporarily implanted nitinol device. It has the first and second generation devices. So the implant, it gradually expands the prostatic urethra and thereby alleviate the symptoms. And in addition to that, water vaporization, it uses the convective radiofrequency thermal energy, thereby it denature the tissue and ablate the adenoma, and it has high likelihood of preserving the sexual function. And we have the photoselective vaporization of prostate. It uses the green light lasers and thereby it ablate the tissue, and it can be used for the patient with medically complicated patients, those who are on anticoagulants. So the laser enucleation that involves the holmium laser and the thulium laser enucleation, it has advantage of coagulation of tissue without deep penetration into the tissue. And the prostatic artery embolization, it's less effective compared to the TURP, but it's still under investigation. It needs collaborative work between the urologist and the interventional radiologist. But it has the advantage of reduction in blood loss and need for catheterization and less number hospitalization time. So TU transurethral vaporization of prostate, it's a modification of standard TURP, use number of energy devices to burn the prostatic tissue. And transurethral microwave therapy, it's an earliest office-based invasive surgery, and it now likely replaced by the other minimally invasive surgeries. So considering the simple prostatectomy, again, we have in Sri Lanka, we are still practicing as long as we don't have the other enucleation procedures freely available. So still we are carrying out the open prostatectomies in patients with larger prostate, particularly more than 100 cc.
Excuse me, I think if you can summarize, Dr. Sasikumar, I think in the interest of time, because we have an oration hereafter. So.
And regarding the take-home message, the evaluation of patient, the important thing is not assuming the patient of above 50s are with LUTS due to BPH. So it's important to diagnose a patient while rule out other causes of LUTS. It has to be started with history and examination, and we have to evaluate for the possible malignant prostate for the cause of obstruction at the same time. And the aim of management involve improvement of LUTS and improve the quality of life rather than managing the enlarged prostate. And at the same time, we would consider prevention of progression of the disease and treat the complication and minimize the treatment-related side effects. And we have a lot of modalities available, and we have to choose between the patient selectively, depend on the available evidence and patient preferences. Thank you.
Thank you, Dr. Sasikumar. We'll conclude this session now, and may I call upon all the speakers. We have souvenir for the local speakers, and Professor Abhay Rane, has already got it, I suppose, yesterday. And I must thank Professor Abhay, Rane, Dr. Vickneshwaran and Dr. Sasikumar for their excellent presentations.